increase my frequency a little bit. Touch my transducer, make sure that I've got a good orientation. Again, first thing I want to do is set my depth and technique. So I'm going to just take kind of a survey to see what I'm up against. Take a breath from you, Maria. Hold it right there. See the heart. See the liver coming in. So I'll just take a little sweep here. Get my bearings about me. Breathe. Sag. Liver. And I'm going to go medial to lateral. And I'm only going to label this once because I'm going to start kind of pseudo-medial on her, and I'm going to work my way to the right lateral. So that it just tells my doc, and then I have to keep labeling like left liver, right liver. Now again, just like the aorta, actually opposite of the aorta, my area of interest is now just the liver, so I don't have to set too deep. Although on the way across, I do want to image just my proximal aorta if possible. Take a breath for me now and hold. So there's my little tiny piece of liver. I'm going to go just outside of it. I'm going to start here, and on the same breath, I'm just going to take tiny steps, breathe, and I start to see her proximal aorta right there. So I know exactly where I am. I'm slightly to the left of midline. Change my depth a tiny bit. Take another breath for me, please, and hold. So I saw her aorta. Breathe. I might want to just stop and measure it while I'm here. In a full abdominal exam, this is what I would do. For your sweep of the liver, you don't have to do that for me, but I do want you to recognize when you see the aorta, and I want you to include it because it's a landmark. Take breath again and hold. And then I'm going to take one shot of the liver between the aorta and the IVC. Breathe. My IVC coming in. I'm going to go back and show you that last shot of the liver. Right here. You see there's a line here. And when we were talking about, just going to skin live, take a breath and hold for me. There's an echogenic line right here. This is called the ligamentum venosum. And it's this little lobe of the liver. Go ahead and breathe. It's called the caudate lobe of the liver. And we'll learn about that it's unique to the liver in that it's very close to the IVC and aorta. So it really doesn't rely as heavily on the portal vein and the hepatic artery because it has arterial and venous drainage right here. So often it might be spared when the liver's under attack from maybe fatty liver or hepatitis or cirrhosis or some other liver disease. The caudate lobe may be spared. So we want to always include this ligamentum venosum, and it sits literally this lobe between the aorta and the IVC. You want to stop, show this ligament and this little tiny piece of this liver, and you can see the borders come in and it kind of dips in and then comes out again. That's a key that you're looking at the ligamentum venosum.
Looks like a nose and mouth.
Doesn't it? And even here I can already get a sense of my liver. This is part of that left portal vein. See how bright it is? And remember the H and the legs? These are part of those stems coming out from that vertical rise. So we're in the lateral lobe of the liver here on the left side. And then you can even start to see maybe branches of the hepatic vein that'll be coming in very soon. Okay, let's go back. Hold your breath for me. So right after that, I should run into the IVC. And voila, I did. There it is right here. So I'm approaching the right side, and the next thing I'm going to find is my porta hepatis, right? And that's where my portal vein is starting to come into the liver. I'm not going to see it elongated because I'm in a sagittal plane and my portal vein is not in a sagittal plane. But I'm going to be seeing the portal vein starting to enter right here at the kind of the hilum of the liver, except we call it the porta hepatis, right? So totally looking for that. Take a breath and hold. There's my IVC. Breathe. There's my portal vein coming in. This is probably part of the left. I'm not seeing my main portal vein. It should be here, but this is duodenum right here that's shadowing for me. And I've lost my sagittal. Where's my liver? Under. There's a lateral. Now, right past the IVC, when you hit the IVC, I want you to think, I have to change my depth because now this is my border, this is the diaphragm, and if I don't see the diaphragm under here, I'm not deep enough. All right, so let's change our depth. Big breath again for me and hold. Breathe. So you can see now I have appropriate depth, and it's quite a bit. I'm at a little more than 20 here. Let's go back in.
So you just add more depth just for that one shot, and then you just go back?
No, from here, when I hit that IVC and I kind of dive off the spine, I know I'm in the deepest part of the liver, so I'm going to stay probably at 20 centimeters for a little while because the whole right side of the liver is stacked anterior posterior on itself. But I'm also kind of at that no man's land, big breath for me, right at the porta hepatis, where I may, she's going to let me scan her intrahepatically. Okay. Subcostally. Like I'm barely catching her liver here. Breathe normal. Aren't scanning for me. So right about here I have two choices. You can see I'm coming into bowel gas here and I'm getting a good shadow, and I may not go any further than this. I'm going to be angling up a little bit and angling towards her liver, and stay here for as long as possible. Some facilities, even if you can scan your patient all the way through subcostally, when I get here, I'm going to actually angle over. I don't want to just stay and come over her rib. I'm going to just come over here and just shoot my beam like a flashlight at this lateral aspect of her liver. So I'm going to come over, angle up, start to angle a little bit, not too much, or you're going to miss, right? So I want to be catching my kidney as I go over, and then we're going to run into her ribs. If I can't go any further this way, or even if I can, I might use that intercostal approach. Go back. Usually I try to find like the IVC. There it is. And then I'm going to work my way through her liver intercostally. See, I've got that window. Isn't it beautiful? And my depth doesn't have to be quite so deep there, but I can go from her IVC pretty much all the way through until I'm out. You can see in my rib shadow I've got kind of nothing. So my last shot's going to look something like that. Okay. So you made it kind of to your porta hepatis. Deep breath again for me. Here's your gallbladder. Slide over a tiny bit. Now when I'm about here, I want to measure her liver. And the way I'm going to do it is I'm going to think of her clavicle, come straight down the midclavicular line. There's her kidney here. Deep breath for me. Hold your breath. You're not going to give it to me, are you? Breathe. I'm going to do it intercostal here. So here's the kidney. This is the shot I wanted subcostal, but you can see here's bowel gas, and that's what I was trying to compete with. So I'm going to take this shot. I'm going to grab the tip of her liver, and then I'm going to come over and basically hit the diaphragm at about a 90-degree angle. And we're measuring 15.6 centimeters. That's within our normal liver limits for the size of the liver. So pull there. And now I'm pretty much just going to stay intercostal. And I want to go back because I can see her liver better than intercostal, so I really don't want to sit here and fight trying to get pieces of the liver that are not going to be that great. So I'm just going to go ahead and go intercostal. And I'm going to sweep kind of medial to lateral. And I'm just going to go ahead and pick up that IVC. And you can see here's her gallbladder. So that's kind of my landmark. And I'm going to just take a step away from that. The nice thing about intercostal is the patient does not have to sit there and hold a big deep breath most of the time. Because if I do, take a big breath for me, it kind of goes away. It's worse, right? Breathe normal. Sometimes expiration is really better on this one, or just let the patient breathe. You see these are rib shadows. There's a rib, shadow, shadow. I'm just going to try to work my way around those. And now I'm kind of out, right? So that's nothing to see here. And then usually at the end of every exam, I'm just going to do kind of another view through the liver, just to make sure there's no masses or tumors or something that I might have missed. Happy with that. The liver kidney shot, this is really an important one, whether you do it on your way through the liver or even after the liver. The echogenicity, remember we have a criteria for normal. Is the liver in the right place? Yes. It should be in the right upper quadrant? Check. Is the liver the right size? We measured it. Yes. Is the liver the right shape? So the shape we're going to evaluate kind of here at the edges. See how it tapers nicely. And at the, hold your breath for me, midline also. Everything has kind of a nice shape to it. When we start to see the liver enlarge, instead of these kind of crescent borders, you'll see a big rounded border. So it gets bulbous. And even at the caudate lobe, sometimes you'll see a very bulbous type liver. Or at this kidney shot, it'll bulge out this way, and sometimes it looks like the kidney's like, help me, because it's compressing the kidney, right? So it's only got so much space in the abdominal cavity when the liver enlarges. So you'll see compression of the kidney, you'll see rounded edges here. So is the liver the right shape? Check. Is the liver the right echogenicity? The kidney should be hypoechoic or isoechoic to the liver. Those are both considered normal. Her kidney is hypoechoic to the liver, check. Now we're going to evaluate the texture. Is the liver homogeneous, a very smooth, similar texture, or does it look spotty and ratty? She's a very homogeneous liver, right? So the texture is homogeneous, the shape is correct, the echogenicity, it's not too dark, not too bright, check. So we can use all that criteria to say, we believe that your liver appears normal, right, to the radiologist. Now the patient's blood work might say otherwise, but she's not showing physical signs of liver disease. So that's where that one part of the assessment of the patient, where maybe they come to us because your liver enzymes are off. We want to see what's going on in your liver. Nothing much to look at here, so maybe the doctor's gonna, alter your medications or blah, 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 to treat whatever they believe is ailing. For the criteria that we have, she meets the criteria for normal. Make sense? Okay, how are y'all feeling on the liver? And did you notice I didn't really even pay attention to the hepatic system or the portal system very much, but certainly the branches are there. Here's our main portal vein. Usually at the end or somewhere in the abdominal scan, we do want to evaluate the main portal vein. So let's go and do that. And of course the intercostal approach is the best. Here's my color here. don't have to say hepatopedal because we're demonstrating that it's hepatopedal. I'm gonna take my color off and see if I can measure this. Okay, so now my subject area is just my portal vein, and I want to get a better shot to measure it. I'm going to go lumen to lumen, inner to inner. We want it to be less than 12 to 13, and it's 0.7 or 1.7 centimeters or 7 millimeters. So there's our portal system. We won't see the transverse view of the right and left until we go to our transverse liver, right? So we're going to do that next week, but so don't even worry about that part. Okay. Anytime when you're sweeping across and you see something really beautiful, take a picture of it, right? I saw a hepatic vein. Why would I pass that up on my way across the liver? I'm going to stop and just take that landmark, keep going until I see something else. Once you get to kind of the mid-liver porta hepatis, there's not that much going on in the lateral aspect of the liver. It's just going to be liver, except for the kidney.